Dear healthcare, it's you. Med students experience abuse in medical school.
As medical students at that time, we were supposed to be on call every fourth night.
Okay.
On call means you're up all night going around with your resident to see patients.
Okay, you are in the hospital.
You're in the hospital,
Okay.
you're running around doing this. So this is every fourth night, right? Which means, you over the course of a month, you have about a week where you don't sleep at all. Right. You go the whole night without sleeping, right? So 1 week out of 4, in fact, just imagine trying to do that every month, right?
Yeah.
1 week out of 4 you're not sleeping. This is pretty common in the medical profession.
Because you would have stuff you need to be doing during the day too, you're saying?
Exactly, yeah.
It's not literally zero sleep, but yeah, it is very little sleep. Like you're getting 20 minutes, 30 minutes here and there between your pager going off, but you're not literally going 7 days with 0 minutes of sleep. But yeah, it's incredibly toxic. It's incredibly unhealthy. It's not safe for patients. It's not safe for the person. Like I almost got into an accident reversing my car post-call after like a 34 hour shift. But I had been up for probably 36 hours because you have to wake up before getting to the hospital, obviously. It's not literally 7 days no sleep, but it's very, very little sleep for 7 days, and it's incredibly bad.
You'd come in, you'd work all day.
Yeah.
You would then work all night.
Yeah.
And then you work the next day until about noon.
Yeah.
This is how it was done at that time, right?
Also what I was doing in residency too. That day, for example, where it was 34-ish hours, same thing. You work the first day, the whole night, and then up until noon, and then you get to go home.
But here's the thing. So the normal policy in that institution was you come in, you write you work all day, you go all night. And then you were supposed to submit something called a history and physical document. What you were supposed to do was take one of the new admissions that came in from that evening, right? And then 4 days later, on your next on-call cycle, you were supposed to submit a written document that said, here's all the information I gleaned.
Okay.
Here's my thoughts about possible diagnoses and which one I think is the most likely and what treatment we should do, right?
Okay.
So everywhere else, all the other students, for the most part, they had 4 days to churn out this written report.
Yeah.
We had to present it by 8 a.m. that morning after we'd been on call all night, right?
And when did the night shift start?
I think it was about 7 o'clock at night. So you had from 7 a.m. to, and I'm sorry, maybe it was 8, whatever. It was about 12 hours approximately at night, right? And then you had to have this thing handed in by the time he showed up in the morning. So you had to write it overnight, right?
While you were supposed to be doing
While you're supposed to be following your resident around and seeing patients, right?
Yeah.
So that's interesting. Med school, residency, experiences are different based on the rotation, the institution, and your year in training. So my toughest week in med school was during my 4th year on an away rotation in plastic surgery, where you need to work extra hard to impress the people at that program that, hey, I'm a hard worker. I hope that you will consider me for residency. And we were on, so plastic surgery as a service is on call for plastics, facial trauma, and hand trauma. They call that triple call because face and hand are shared with OMFS/ENT for face and ortho for hand. So triple call weeks are the worst weeks. And I was the med student assigned during that triple call week. And every day we were just getting rocked. Each night I'm getting literally 2 to 3 hours of sleep. 19, 20-hour work days are the norm for a full week. Brutal, right? Not necessary, not helpful. Doesn't actually tell you who's gonna be a better or worse doctor. It just tells you who is willing to put up with more sleep deprivation and can maybe handle it better. This gentleman looks like he's a bit older than me, so I'm guessing that he went through med school sooner than I did. But even in, I graduated, 2017? So even in the 20-teens, this is unfortunately largely the norm.
So 2 things happen. The first thing is that we start, because he's required us to turn in this paper, right?
Yeah.
So we start saying, okay, residents, well, we need some time to write this.
Yeah.
We cannot follow you around all night. The residents get super angry with us for not following them around.
He's probably at an East Coast program because on the West Coast, there's so much more chill. I remember when I was a resident and I had med students, if they needed to do something or couldn't be up, I'd be like, okay, cool, sure, no issue. And most of my co-residents were the same. It wasn't, how dare you? You're stepping away from what?
So we meet with them and say, we can't, it was myself and another medical student. We say, look, we can't go with you. We have to write these papers. We're being required by our attending physician to write these papers, and we have to turn them in at 8 a.m. And you know this.
Right.
And their response was, well, that's not our problem. That's your problem. You need to talk to them. But if you continue to do this, we're going to have to write you down on your evaluation.
That's wild, dude. By the way, for those wondering, this is white tip oolong from Teabloom, teabloom.com. Use Jabal10 for 10% off your tea and your teaware. which this is also from T-Bloom. It's insulated so you don't burn yourself.
So, and would this attending physician be over these residents
Yeah,
as well?
yeah,
So they
yeah.
like that's their direct boss, and they just still
They
would
didn't
just
care.
be like, whatever.
This was the response.
I'm your boss.
This is the
also.
response
Like,
we received. Yeah,
Wow.
that's it. I'm your boss, and I want you to follow me around. And even though, so you see what I'm saying? We're
But
at
there
the-
was no backup from this attending physician
Right.
to be like, no, guys,
That's
I
right.
actually need them to have this paper in at 8.
we're
Like,
at the bottom of the
there's
of the
no-
hierarchy.
Again, no communication
Right.
across, and
Yep.
then you guys are screwed.
Right.
And this is the culture of healthcare. I wonder if some psychologist or psychiatrist has dived through why certain fields and careers like healthcare, especially surgical fields, tend to be this way. Hey, I suffered a lot. This is how things are done. You have to suffer a lot. Now it's your turn. There's this hierarchy. You're at the bottom of the totem pole. You get treated like shit. As you work your way up, you get treated slightly better. But still, throughout residency, it's still pretty bad. I'd like to think the newer generations are more chill and aren't reinforcing that culture as much, but I've still seen it happen. At one program that I won't name, an attending physician was upset with a resident because they draped the patient incorrectly or whatever. And they threw a loaded scalpel at the resident. Luckily they missed, but that's fucking wild to me. I think the attending then took a leave of absence, but wasn't even fired.
Yep.
Yeah.
So we're making our residents mad by not following the culture at that place. Was
Right.
you follow them around until they dismiss you. You can't go anywhere, right? And if you do, your name is mud, right? If you do that. So we're in a position of, well, but if we do that, then we can't finish our paper. And if we can't do that, then our attending will be mad, right? So what do? We just got stuck in this purgatory between
Yeah.
the two things. So then what would happen is then you'd hand in your document. He didn't want you to just hand it in. He wanted you to give an oral presentation. But before he would do the oral presentation, he would take you on about 2.5-hour walk arounds. So you'd walk around to see all these patients.
We call it rounding, right? Rounding in the mornings. And you can also do afternoon rounds where you go see the patients again, but as you're wrapping up the day.
And during that process, he would do a process that in medical parlance is called pimping, which basically means keep asking you questions.
I also don't know where the term pimping got applied here because it's based on its other context, kind of a strange term to use, but your higher levels are quizzing you and seeing how much you know. And it's normally done in a very high stakes, try to be as stressful as you can kind of way. And if you get the question wrong, there's this huge group of people around you and you feel like shit and you better remember it. And it's just, now that I'm outside and reflecting back on this, it's kind of wild, man.
So I'm asking you questions about all kinds of different aspects of the patient and their care and diagnoses and what's the differential
While in the
diagnosis.
room with them, or while
Both,
after?
both while in the room, while
Okay.
walking around, whatever.
And, well, sometimes it's about the patient, but oftentimes it's just about the general anatomy or pathophysiology in general. Saying, hey, what is the structure right here? And if you don't know, then they want to make sure that you feel like a clown. And well, let me clarify here. There are some residents and attendings who are so cool, and they'll pimp you in the most like Socratic method possible, where clearly they want you to learn and improve and become better. And that's why they're doing it, because it's active learning. And then there's those that want you to feel like shit and want it to be stressful and want to ask you near impossible questions and want to keep upping the ante and then berate you when you get things wrong. Those luckily are not the norm, at least in my experience on the West Coast primarily. That's not the norm. And the reason I'm talking West Coast, East Coast is the East Coast is known for being more malignant, a little bit more of this kind of hardcore culture, whereas the West Coast, on average, again, not for every institution, but on average, trends here tends to be a little bit more relaxed and more of the, hey, I'm gonna pimp you, but I want you to learn. You will occasionally still come across the resident who, I know one resident at my med school, actually, who was in general surgery, who was a miserable human being. And she got held back 2 years because she did not have the technical skills to progress past whatever PGY 2 or 3 that she was at. And the attendings were like, yeah, you don't have the surgical skill to go to PGY 4 or 3 or whatever it was. And she was just a miserable human being. And maybe because she felt frustrated there, she was displacement onto med students, and she would take it out and just make you feel like shit and try to belittle you, maybe as a way to make herself feel better.
So you've been up since 5 a.m. the previous day. It's now 10 a.m. the next day, right? Okay. And you have somebody like just blasting questions at you the whole time, right? And then at the end of that, when you go through that whole process of walking around, now he wants you to give an oral presentation of this multi-page paper that you just had to write, right?
A few hours before, though, so it's not
Right.
very recently in your brain.
This
That's
is-
fried at this
Right.
point.
Yeah.
Like,
This is the
is
issue.
there any break in this night?
No.
Not at all.
You just roll all the way
Really
through,
don't.
right?
Wow.
All right, so Dr. Yaghmai is this gentleman's name, I believe, and he went into internal medicine or med peds. which makes sense because it sounds like this was surgery, and it sounds like he did not have a good time on surgery. Or maybe this wasn't a surgical rotation, I'm not sure. Surgical rotations tend to have a more malignant culture. This is such a tough topic to approach because there are certain things that I think are very much crossing a line. And then there are other times where, I don't know if it's Stockholm Syndrome or what, but it's kind of fun and kind of funny. So I was mentioning that other rotation, the away rotation I did in plastic surgery where I was working triple call. I think the week prior or something, I had been shadowing one of these really big name plastic surgeons at the program. That's actually the main reason I went to rotate at this program. I really respected this guy. And he asked me to make a presentation on the fish that have the highest mercury levels because he had made some kind of comment to a patient in clinic about fish consumption. And I said, oh, is that because of mercury after we left the room? And he said, no, but why don't you make a presentation at next week's grand rounds talking about the fish with the 5 highest levels of mercury? And I mean, you can say that that's cruel and unfair and whatever, which I can see that side, but I also thought it was kind of hilarious in a way, where I wasn't giving a presentation on anatomy or surgical techniques or some new research. He wanted me to create a presentation on mercury levels in fish. And I've actually shared that presentation right up here. You can see the PowerPoint. I go through all the slides and I put a lot of memes and such. I was having fun with it. And I don't know, maybe it's the come from, but the come from, I could see he clearly cared about education, but he wasn't afraid to fuck around and have a good time as well. So he still was teaching me a lot. I still respected his, I mean, in the OR, he was teaching me so much and he was pimping me in a way, like the Socratic method, trying to help me learn. And I actually very much enjoyed my time with him. And this one instance of the fish mercury PowerPoint, for whatever reason, doesn't feel toxic to me. It's like, it's kind of cruel because I'm working triple call shift and I need to present that same week in the middle, maybe it's like a Thursday, and I've been sleeping 2 to 3 hours a night, and now you want me to go home and work on this presentation. Oh my fucking God, I'm so stressed. But for whatever reason, it's also kind of funny.
So some doctors, when they do this, their goal is to teach you.
Right.
Meaning they're asking
There you go.
questions. The point is not necessarily whether you get it right, whether you get it wrong.
Right. It's to be constantly seeing what you know, give more.
And to help, to some degree, to help you learn a thought process, right?
Okay.
You don't know the answer to this. Why don't you know the answer to this? Well, let's explain what thought process would get you to the right answer.
Like
right?
partly like helping instill that flow chart
Yes,
within you. Like
that's
muscle
precisely
memory for
it.
that. Okay.
That's precisely, and that's, if you're going to use that technique, not everybody does,
Right.
but if you're going to use that technique, that is how it should be used.
That should be the goal.
Well-implemented Socratic teaching method.
The point was to rub your nose in what you didn't know and how much more he knew than you did.
Really?
Oh, 100%.
And those people, God, I'm gonna get some fire for this, tended to be in certain specialties. They tended to be surgical specialties, but I don't think it was very common in plastics. I remember rotating on neurosurgery and ortho, and it also was not very common there. I actually thought the neurosurgeons at my med school, which was UCSD, I did a rotation because I was considering plastics, ortho, neuro. I thought they were the funniest guys because they rocked the whole arrogant neurosurgeon stereotype in the funniest way, and they weren't taking themselves too seriously, and they were never aggro and trying to humiliate me. It was certain other surgical specialties that I'll let you figure out.
So it would be, I'm going to ask you questions, right? If you don't know it, I'm going to just humiliate you for not knowing the answer to whatever the question is, right? In front of the whole team and everybody else, right?
Yeah.
I'm just gonna tear you down for not knowing.
So this is happening in front of other people
100%,
as well, yeah.
100%,
Not
yeah.
just,
It's the whole team,
wow.
the whole residents, everybody else that's there, right? So you're just getting dressed down for what you appear not to know.
And the fucked up thing is that those people that want to make you feel shitty, they'll keep upping the ante. So maybe they'll ask you one question, okay, you got that question, and then they'll ask a more advanced one. And if you're a really good student, they will have to go beyond your level of training. Okay, I'm no longer asking M3 or M4 questions. Now I gotta ask, even though you're a 3rd or 4th year med student, now I gotta ask like PGY1, PGY2 level questions. They're just looking until they stump you, because they will be able to stump you. But you get no credit for doing the M3, M4 level questions. They're just gonna pin on you the fact that you didn't know this PGY2 level question. So you get no credit. It's just a lose-lose all around.
You know, there was one experience I remember having. The case was a guy that had come in with abdominal pain, right? And he had liver metastases or something like that. So, I wrote up my paper on potential causes of liver metastases in this case, right? The thing about this particular doc was that he really enjoyed cardiology. That was his thing. He knew way more about cardiology than any of us did at that point in time, right? So, and most of the cases we had coming in, a lot of them were heart cases. So we learned very quickly, if you do a heart case, he's going to just tear you to shreds because he knows so much more than you do about this. So we learned, the two of us learned, we probably shouldn't do heart cases because, if you don't want to just get blasted, you got to do something that's a little bit out of his area of intense expertise. So we would do this, right? So we'd pick side topics, right?
Yeah.
And so, I picked one that was abdominal pain. And I finished up my presentation. He's clearly very frustrated because there's really nothing that he can go to town on, right?
Yeah.
It's a more limited topic, which was intentional on my part, right?
You're being smart in how you try to dance around these
we're trying, right?
Like,
So he says, well, tell me the differential diagnosis. Differential diagnosis means give me a list of possible diagnoses that could cause this symptom.
Okay.
So he says, give me the differential diagnosis for abdominal pain, right? So I'm like, okay. So I start naming diagnoses, right?
Yeah.
So I go on for about 2 minutes or so, naming everything I can think of that could cause abdominal pain. I finish up and he's like, ridiculous. You forgot hereditary spherocytosis.
Like the lowest item on the differential.
Oh my gosh. How could you forget?
Right. And I'm like, you know what I mean? And I'm like,
right. I mean, when you type in them to Google, we now know that there are so many things that can.
I've never forgotten that though. To his credit, I've never forgotten hereditary spherocytosis.
Right.
Okay.
How often does it come up in your diagnosis for real though?
But it was virtually never. But it was, this was the goal, right? And so there were lots of insults. There was lots of tearing down, on a very personal level, insulting your intelligence, insulting you as a person, not just you need to know more, right?
It was an attack.
You're an idiot, right? It's like this kind of thing. This was the dynamic. So, my co-medical student, right, started taking those papers, right?
Yeah.
I would try to write what my co-medical student started doing was cutting and pasting out of pre-written medical journals. So look up a topic, cut and paste, and slap it into the paper, and then read that, right? As the thing,
that's
right?
funny.
He didn't know that this was going on, right? So he'd be like, "Oh, that's wonderful. What a wonderful." I'm right.
Oh my God.
Yeah, I'm like, well, that was written by a medical professional, right? That wasn't written by a medical student.
A med student.
You don't know this, right?
Right.
Okay. So I'm trying to do it allegedly the right way. I'm trying to write it myself, right?
Learn
and you are just ripping me to shreds, right? Well, this is going. So this is the dynamic, right?
Yeah.
So I take that.
Which kind of goes to what we've talked about before of like the type of person that ends up in medicine.
Yes.
By the way, you will have to do presentations in med school. I used to be so deathly afraid of public speaking. I was the worst public speaker, voice shaking and all that stuff in high school. And even in college, it didn't get much better. And in med school, you just kind of sink or swim, baby. And you will have to do a lot of these presentations. So at that same rotation where I did the fish presentation, they had me do something else, but it wasn't that memorable. It was actually at grand rounds. There were a lot more people, and you're teaching everyone about some kind of surgical technique that obviously you as a med student know very little about in comparison to this group. It's not just one attending, it's like this group of attendings and residents that are now gonna ask you questions. But I think what goes a really long way is just managing yourself in those situations to not get flustered. If you don't know something, say you don't know it. Don't make up some shit. They're gonna shoot you down and then humiliate you for pretending like you knew something and bullshitting when you didn't. So you answer what you know, and what you actually do is you present. Let's say you know this much about a topic. You actually only present 60%, and then you learn a little bit more around the edges, so that when they ask you those questions that are surrounding the topic, you can answer most of them. And then when they start going further out, okay, you may not know that, you say you don't know, but they're satisfied because most of the questions they've been asking around the core topic, you actually did research beforehand and you have that in your back pocket, you just didn't include that in your presentation. So a little bit of strategy there so that you look better doing these presentations. Don't give it all away, hold a little bit back so that you can actually answer their questions and impress them.
Just check the box, like not just check the boxes, but it's an achievement thing. Like he's like accolading this person who's got all the right information, whether they've learned it or not.
Correct, right. They have learned a way around, they've learned to achieve an outcome, right?
They've learned a way around.
Whether they learned that information or not is irrelevant, right? They learned how to present the appearance of knowledge.
Right.
Right. And I don't fault them for that. It was an extremely high stress, awful situation, right? But
points out a flaw in
that's
the
what was
system.
going on, right?
Perverse incentives. The incentive is not to actually learn the information. The incentive is to not get totally destroyed after or during this presentation. So the perverse incentive then results in you doing these behaviors that don't have the desired outcome of you actually learning. But generally speaking, I mean, copying and pasting from these medical documents, most attendees are going to catch that a mile away, because what you're supposed to do in med school, from my experience at least, is summarize topics. So whether it's on internal medicine rotations or surgical rotations or wherever, you will, based on maybe some patients that you have on the floor at that time, you'll be asked by your residents or attendings to teach the group whatever disease process or whatever differential diagnosis, et cetera. And they will ask you questions. But by you doing that, it is an active learning process because you are creating the learning material, right? So doing all that research, compiling it, comparing and contrasting things, and then also teaching someone else, the Feynman technique, right? So it's actually a very good teaching method if used in the way that it's designed. It's almost like a beginner step to the see one, do one, teach one that they say in medicine. So you see something being done, you do it yourself, you learn, and then you try to teach someone else.
You're teaching them to find a way to give you the outcome you say you want, whether or not it has any actual effect on how good of a doctor they are or how knowledgeable they really are, right?
Yeah.
And you're making no allowance for the fact that this person, by definition, has less knowledge and expertise than you do.
Yeah.
You are a better doctor than them. That's why you're teaching them, right?
Right.
The point is not, this is not a battle of equals, right? This is a battle of the clear power differential.
Mentorship, for lack of,
except it's not, right? It's like a reverse mentorship.
Right.
So this was the dynamic, and this was the problem. So you learn to produce the desired outcome rather than go through the process that might actually make you better at the job in the long run.
Right.
So I take that dynamic and I went to the clerkship director at that time and said, "Hey, this is the experience we're having.
Yeah.
Like, we're getting just torn to pieces.
Yeah.
What we're being asked to do is not comparable to what our colleagues, our other medical students, are being asked to do by their attendings. We are being held to a different standard."
It was like you talked with your
100%.
Yeah,
we knew it was going on. Yeah. So I go present this, and he says, "Yeah, that's true. Yeah, we hear about this guy every year. Every year we hear about him. Yeah, he's like that." And we're like, okay, and so what's the plan? Nothing. The plan was nothing. The plan was, just suck it up. Like, that's, we know he's like this. He treats everybody like this, and just deal with it. Like, that's the answer.
You got the short straw. Like.
That's exactly what it was. Yeah.
Dude, I had a similar situation where, not as bad as this, but I was on a psych rotation. And psych is actually very important for plastic surgery. So I was working my butt off trying to honor this rotation. I'm a third year med student. And two things had happened. The first is that the attending had paired me up with this psych patient who had psychosis and delusions. And she would point at me and say, it was very explicit stuff I can't even repeat here. It was very uncomfortable, and she'd be banging on the table and like yelling and screaming and like foaming at the mouth. It was very uncomfortable. But he still had me interacting with her. I was like, hey man, like, I would hope that in that situation, given how volatile she was, that he would probably handle it. Even though this patient is clearly unhinged, I never made one peep. I did not want to complain about it, because the med student way is you put your head down and you just grind it out. So I worked through it and I did my best, and he could see what was going on, and it was almost as if he enjoyed it in some kind of sick way. And while most people have very chill psych rotations, I remember mine being particularly challenging, and I put in a lot of effort because I knew how important psych grades are to plastic surgery. But anyways, he's an interesting character and seems to have fun with it. And at the end, I get not an honors, but there's like honors, high pass, pass. I get a high pass, and I did really well on the shelf exam, the actual written portion, and then your overall grade is your written portion plus your clinical evaluation. And I remember being confused, and I look at the evaluation, and he wrote that I was operating at a 4th year med student level. I'm like, okay, solid. So that's honors worthy, right? I'm going above and beyond my 3rd year expectations. And then he said, but this is towards the end of 3rd year. This is like the second half of 3rd year. Therefore, I'm kind of expecting you to be operating near a 4th year level. Anyways, and I was like, so I'm a 3rd year operating at a 4th year level in your own words, but somehow that's still not good enough to have honors. And anyways, there's some attendings that you get paired with them because you get assigned to different rotations and you don't know who you're going to be working with. It's kind of luck of the draw. And sometimes you just get assigned to someone who's kind of a scumbag.
Do you send it to your attending physician?
No, I sent it to the clerkship director.
Yeah.
So I documented the things and sent him a letter. And his response was, it was too long, I didn't read it. Just don't care, right? So you just deal with it, right?
Savage.
So yeah, this was So again, right?
Yeah.
The vibe here is
Put up with it.
put up
You'll
with
be
it.
gone soon.
We have an institution, right?
Yeah.
We're gonna do what we're gonna do. If it's abusive, it's abusive. You should just live with that, right?
Yeah, so I don't like to paint things black and white. I think medicine culture needs to improve. I think it already has improved a lot since a few decades ago. I'm guessing that's when he was in medical training himself. And there still needs to be more done to improve it further. But I don't want these stories to scare off pre-meds or med students because it is variable. It depends on who you're working. It depends on the location, the institution, the specialty, all those factors. And chances are you will have some distasteful experiences, but hopefully most of your experiences are going to be quite positive.